So this is a guy, and this is kind of a how do you approach type thing. So I'll definitely get Eric's, Chuck, Pyam, anyone involved, how they would actually do this. I think this is one of these acetabular cases where it's more on decision making, not whether to operate or not, but just more on decision making and approaches. And I think this sort of for me was so I did it one way, but I would love to see how everyone else would do it. And that's kind of why I brought this up for discussion purposes. So this is a 25-year-old guy, MVC, stole a Ferrari and ran from the cops, and crashed crashed a Ferrari down the cliffs of La Jolla. And so anyway, he was brought in and had this X-ray. So you can see right here, or you can already tell he has got some sort of acetabular fracture with a dislocation of his hip. This was basically reduced promptly, and so he was reduced, and then he was put into the CT scanner. And so this is kind of interesting because, I was going to put it on this talk, but I felt like it was going to be too much. But he was brought in. So I want to say promptly. He was brought in and he had a CT scan with him dislocated, as they always do, right? They go straight in. And you can tell because his whole hip is totally out and he's totally internally rotated and he's totally, he has some deformity there, but they still threw him in the CT scanner. But I would tell you that in the CT scanner, he had from the CT scan of his pelvis, he had no posterior injury that I can tell on the CT scan. Once it was reduced, we did a repeat CT. And so this is now what it's showing. So he's got obviously some right-sided SI injury. And then he's got this. Fracture, obviously involving both columns. So he's got this transverse posterior wall. Got some impaction in the joint posteriorly. Some free piece, some osteochondral piece over here. Kind of a mess, yeah. So here's his 3D imaging. So sort of like like these, transtectal, maybe very high juxtaposition, but this is transtectal. It's a transtectal transverse transverse posterior wall.
Can you go back to the axials?
Yeah.
Okay.
And then here's the back. He is dysmorphic, as you can tell. Okay, so he's got the mammillary body and stuff, so he's dysmorphic. Okay, so now I guess the question is, this is where I would love to. How are you when you see this? What's your thought process, and how would you go about in terms of your operative strategy? What are you doing?
I mean, just me and just me and the biases I was trained with.
Yeah.
I would start. Obviously this is operative, so there's no.
We're not debating that. Yeah.
I mean, personally, I would put a traction pin in his distal femur, turn him prone, put him in traction, and hopefully get some good distraction in the hip joint, and ideally get some indirect reduction of his SI joint at the same time. And if I didn't, I would hope that a appropriately placed lag screw would then finish whatever reduction I needed the SI joint. I would back that up, and then I'd probably do this from the back with I don't know if I would flip the troche or not, because I don't know how much that's going to help me because it's not really so high in the back.
Mm-hmm.
But I definitely go from a coker and pray that I can reach around and through his notch and get a good feel for the the top and the front.
You're going.
I might need to flip his troche for the wall. The wall looks like it goes kind of high.
Chuck, are you going prone, you said, or are you going lateral there?
Yeah. No, prone.
Okay.
I'm going prone. I'm going to go prone and try to get this all through some version of a Coker Gibson or whatever the heck you want to call it.
Mm-hmm. Eric, what do you think?
I agree. I would probably approach this prone initially. I would probably put in a screw on that right SI joint before I did anything with the acetabulum.
Mm-hmm.
I think it's going to be harder to reduce if you fix the acetabulum first before you fix that. I'm still a little bit concerned though that you're going to be able to get an adequate reduction, just the monoclamp and the notch with that amount of anterior displacement. So I think it's reasonable to start posterior and try to line that up as best you can, but just knowing that you may have to flip in with this fresh cutter.
Do you guys have any? Because I know fixing these SI injuries. Because like when you, in the prone position, do you feel like you still have adequate control of getting the SI joint reduced in the prone position?
So the other caveat is that I'm old enough and my training goes back far enough that we actually did a lot of these open. So, which, obviously is a can of worms in a different way. But yeah, I'm not particularly uncomfortable reducing these posteriorly. I think that, it's kind of extending some of our more indirect or non-open techniques. You can put a shank pin into the ilium and start maneuvering the ilium directly. If you've got a star frame, you can definitely put one of those push things against the ilium to, close it down before you put the screw in. The plus side, if you haven't done it, is once you kind of conceptually get used to it, the SI screws themselves are actually a lot easier when they're prone because you're not fighting the butt, Yeah. And if this is old for some reason and you need to open it up, at least personally, I actually think it's a lot easier to open them from the back than from the front. You're just fighting so much more soft tissue when you're going from the front. And I know a lot of people are just much more comfortable with the first window and diving down into the joint that way. But, through the first window, you really only kind of see the top of it. And if you go from the back, yes, you got to look at it a little bit of an angle, but you can actually see the whole thing and you can very easily reach under the notch and feel the front. But yes, it is an approach that's notorious for wound complications. And, and I certainly wouldn't want to combine it with a Coker.
No, yeah, right. Yeah. So one of the things I do sort of struggle with is, because this is well, here's another question. Are any of you guys not messing with the SI joint injury first? Meaning, are you guys trying to see what you can do with the acetabular component first before doing the SI joint injury, or are you doing SI joint injury all the time first?
I just personally think you need to have a stable platform that you're trying to reduce your tab to. So I would always try to get the SI first. And the other thing is sort of consequences, right? If you're a little off on the SI, it's not the worst thing in the world, right? Like it's not. But you want to be as perfect as possible on the tab. So I think you want to create like I said, a stable platform that you can reduce the tab back to. So.
Harmeeth, I think that's a fantastic question because again, something that I experienced as well. So for me, if I'm unsure, I'll do the SI first because I'm unsure. But in my experience, it's exactly what Chuck said, the consequences. So I will, in some of these situations, do the acetabulum first. I put them in the position. If it reduces, then I'm going to fix it, the SI. If it doesn't, then I'm suspicious that my minor adjustments won't make that posterior reduction as anatomic as I think it is. And therefore, it might make my reduction of the acetabulum harder. Mm-hmm. So I will consider it to then do the acetabulum first and get that as perfect as I can. And yes, the concept of the stable platform does matter, but that gives me a little leeway to move things that allow the acetabulum to be more anatomic. Once it's anatomic, then I will accept, did that reduce my SI joint? And if it didn't, if it's not perfect, it's a more forgiving joint. So the fact that you're thinking about it or considering it makes total sense to me. But like I said, I've learned that when in doubt, just do the posterior injury first, because it's a principle that I do think has some basis, and people with a lot of experience evaluated that. And I don't think that principle has been debunked. But I say anecdotally, I have times where I think it went better when I went against that principle.
Gotcha. Yeah. And I don't have the actual in the actual cuts. Oops. Here you go. I don't know if you can see it now. So I'll tell you, this actually. So one thing to make it a little bit more maybe harder is that this. Where's my mouse here? There you go. This right here. I don't know if you can. You see my mouse? Yeah. This right here, even though it looks like it's one piece, it actually is. It actually has a non-displaced fracture through it. So it's not as clean cut as this volume rendering would suggest. You can barely make it out here, but on the CT itself, looking at it, there is a little bit of there's a fracture line here. So if that changes your mind at all, Payam, your thoughts?
I would go supine. Fix the front, either open the SI joint, or if I can do it percutaneously, do it percutaneously. Plate the front of the acetabulum, and depending on how stable he is, either flip him after the front or bring him back another day. But I would go front first, especially with what you just said. If that is a separate piece, you're not going to get that reduced from the back. So I'm pretty comfortable plating anterior SI joint, so I would plate it the SI joint anteriorly or put a screw at the back.
If this was not had a non-displaced fracture line through it, let's say this actually was one fracture, would that change your management at all, or would you still do it the way you just said?
No, I do a lot of double plating front and back. I used to do them all in one sitting, have them in a semi-lateral position. That's how I was trained, kind of have the front and back open at the same time with two surgeons. But I've learned that it's really hard to do that because you're kind of sacrificing both exposures.
Yeah.
So you're doing both kind of half-assed just to get the job done. So now I just do them sequentially or different days.
So the question is, are you doing this for all your transverse fractures, your double plating?
Nope. The ones that I think I can't get reduced anatomically. And sometimes I'll either put a column screw. If I get them done perfectly, I'll just do a column screw as well. Right. But not all of them, just the ones that I think I can't reduce close to anatomic. I'm not going to say anatomic because I don't think I'm that good, but close to anatomic.
Gotcha. I would say that, if I'm going to do that, and, I was trained as a one approach person because that's what Joel did. But I would say that I've definitely done this front back sometimes, I always try to do something that I can defeat, some sort of fixation that I can defeat from the other side if I need to, So I think that's the caveat is, not be very careful about where your hardware goes, because you don't want to bag yourself on the second. There's nothing worse than doing that second approach and seeing a big screw from the front or the back in the middle of the fracture site and just going, now what?
Yeah.
Yeah, and that's why we used to do them with 2 surgeons, front and back. But I can tell you, it was really hard for both surgeons. You're both sacrificing good views for the sake of doing it simultaneously.
Yeah.
So I've given that up, A, because I don't have a second surgeon to help me, but more because it was just really a pain in the butt.
No, yeah, definitely. And it's kind of hard to do that too. So, yeah. So I think for those, and you all make great points. My thought process is that I needed to make the SI joint as perfect as possible because like you all said, you need something stable to build off of. And if your ilium is off, right, you're just never going to get this transverse reduced. And I have more control of the SI, again, in my hands, I have more control of the SI supine than I do prone. So this is sort of what I did so I used the X-Fix. So I did this percutaneously. So I used the X-Fix to reduce the SI joint. You can see that it's really bending. Like there was a lot of pressure onto that to really close that down. And then I placed just positional screws. He's dysmorphic, so he has and he's young, so I didn't go all the way across the other SI joint, but he has an S1 and an S2 transsacral screw. S1 sacral iliac style screw and S2 transsacral screw. And then just like Pime said, I actually did the whole thing from the front. And so I did an anterior approach, reduced the whole front and, put a little, I put an intrapelvic plate in the front. You can see my clamp is basically holding this fracture line at the transtectal part together. And then using that, put a column screw to hold that down. So he has this initially. So, I was there. Again, that's why for these, and I sort of echo what Pime said, is that this was fairly displaced. It's not like this transverse was, plus it's also transtectal. It's not like a gestrectectal or anything like that. This was a really high transverse that was widely displaced. And so I felt like I needed to really be on top of that. That's why I wanted a direct reduction of the anterior column, because I felt like going from the back, I wasn't going to get a whole lot. And if you look at the exit point, my thought was that the exit point was so caudal that I don't think it wasn't going to give me enough of a help of a reduction, even if I used that, the pelvic reduction clamp or anything like that. So I just felt like this was too globally unstable for in my hands, a single approach. So I did that. So he had that in the front, and then we flipped him, and I did it on sequential days. I didn't do it all in one day. And then I fixed, and because he dislocated out the back and he had a pretty comminuted wall and had that impaction, I didn't even stress it. I just did a second approach and treat him like that. And so he had a sequential approach on that one, and then close down the front, and you can see here, close down the transverse component. Wall was fixed. The impaction was fixed in the back, and so that's that.
I think what's interesting is that your SI joint looks more closed down than his uninjured one.
Yeah, I put
that's sort of interesting.
Yeah, you can see that X-Fix was working, and I might have. I mean, maybe there was some occult injury on the other side. Maybe I unmasked something that was there. I didn't go after it, but I really stressed that X-Fix on it to make sure that thing closed down. And then once I was sure that I'm like, I can't get any more, fixate it, because then I know my limbs in space, and then I just reduce everything to that. And so so that's kind of what we got. And that's why I brought this up, because I think these are so controversial. I know Tornetta talked about in JOT, I think 10 years ago or whatever, about no, maybe less actually, but talking about, his algorithm when you have these type of injuries, the transtectal, which ones are you going to go sequential? Which ones do you go all prone? I still think the transverse families are still one of the harder families, because the decision-making is harder. The ones that are minimally displaced, those are fine. The ones that are displaced, those give me a lot of pause, because I still think that I still think that it's hard. Even if you get the clamp to the notch, you put your clamp to the notch, then you got to put. And I got big fingers, right? I got sausage digits. I'm trying to fit in my hand in there. I can't even get my finger down there to see. I'm looking at X-rays, stuff like that. So this way I'm looking right at it, and I know I can get it to where I want it to go. But that's why I was like, I'm not sure I can really get this from the back, or if I get it, am I going to be where I want it to be? And I can't reliably palpate back there with the clamp and the notch and my fingers and and all that stuff. And you're using probably two things, right? You're not just using one clamp. You're also using something else for the ischium, right, to hold that reduction. So you got a whole lot of stuff going on. That's what makes it hard to go prone in one setting. So that's why I did it that way. And it's very interesting, because I like to see what other people are thinking about. So I thought this would be a interesting discussion on just more approaches.
No, I mean, I think it looks great. And, I think you're right. This is one of the more, this and T's, right? Like, these are the ones that kind of drive us nuts, because they're very difficult to do from just one side or the other. And then, if you're going to do two approaches, what goes first? How do you decide? And at least this one, gives you, you had a logic to why you started in the front,
Mm-hmm.
And I think if I was going to stage this one, I probably would have started from the front as well.